Flurry of legislative activity, lots of changes at the state level, presidential tweets, right? So a lot of uncertainty, and amidst that, we still have to do stuff. We still have to go to work and help the members of our community. So I'm excited to talk to you just a little bit about a couple of programs, a couple of things we're doing in the face of all this uncertainty. And so first I'll talk to you a little bit about this partnership project that we've been working on together since 2013, and you can see the list of partners there. With the support of my leadership, Karen at the Health Department, Kara and the DuPage Health Coalition, Candace and Catherine and Kristen at the Federation, Tammy with Northwestern, and Laura Nyberg at Advocate Good Samaritan, we've been able to really develop and grow this program. So I'm going to give you kind of high-level, quick overview of what it is, what we're doing, and then kind of try to focus a little bit more on the lessons that we've learned over the last 4 years, and then go into some of the work that we're doing now to kind of push through open enrollment. So why did we do this? We looked at research that said that really the emergency department in particular at hospitals was being overutilized or misused, or however you want to describe that. But essentially patients were getting care in a setting that not only was inefficient cost-wise, but wasn't really resulting in good quality care for patients. So that same literature and research that pointed us to that problem also suggested that this problem could be mitigated if patients had a regular source of care. So they had regular coverage and they had one person they thought of as their doctor. And so that's what we aimed and set out to do, is to link patients to those resources. We dropped community health workers that work at the DuPage County Health Department into these hospital emergency rooms. We had a process where we're integrated with the hospital's EMR to identify the patients that are most appropriate for the intervention and the assistance. A lot of that, particularly early in this project, keyed on uninsured patients. This project launched the same time that the first open enrollment launched, so there was still a lot of work in DuPage County to do to move people to insurance, newly expanded Medicaid opportunities. And I think at this point, we're pretty proud to say that 97% of children in DuPage County are insured and 93% of adults in DuPage County are insured. So we would engage those patients there on site, try to establish a relationship and some trust with them, figure out what resource they were eligible for. Is it Medicaid? Is it Marketplace? Is it Access DuPage that we're fortunate to have here in DuPage County? And we would work with them over time outside of the hospital walls to make sure that they got connected to that coverage resource. Beyond that, we would offer to meet them in the community or have them at our offices to talk about some of those other needs, some social needs, and also once you have coverage, how do you use it, right? So selecting a managed care plan, finding a PCP that's in network, and then again, addressing those other social needs. So is that food insecurity or transportation or housing, community-based resources, a lot of your organizations that we then want to link people to. I'll just focus on a couple of these challenges. Some of them are really inherent to any new project, but the few that I think are really important, one is identifying the training needed for this type of program and intervention, because it was new, and community health worker is a workforce that's still really being developed in real time. And so figuring out precisely what training they needed has been something that we've kind of built the airplane as we've flown it. So that was certainly one of the challenges. But the biggest two that I want to point to are the two on the bottom. Behavior change in a complex patient population. So just because folks get insurance doesn't mean they know how to use it, doesn't mean it's going to change their behavior. You have adults who perhaps were uninsured their entire lives and suddenly they now come into insurance. So changing their behavior takes time, it takes a lot of coaching, it takes effort, it doesn't happen overnight. I liken it to a lot of behavior change in other fields, in addictionology, where it takes 9 serious quit attempts to quit smoking and 4 interactions with systems of care. So it's going to take time for us to really change the behavior of a population to understand that now you're covered, how you can use that. A foreign concept to a lot of the patients we've worked with is that you'd go to a doctor when you're not sick. So that's a big, big challenge. And the other one I just point to really quick, I think, is data analysis and program evaluation. Can certainly make available to anyone in this room the kinds of things that I'm tracking, what our outcomes are, but I think one of the challenges is really knowing, have we made a meaningful impact from a utilization standpoint, and are people healthier? Are they better off? I think in collaboration with the hospital and hopefully, appealing to insurance companies, we can get a little bit more of a sense of what that utilization data looks like and complete that full picture. But that's been a little elusive to date. Where we're going next with this, we maintain our relationships right now with Northwestern Medicine and Central DuPage Hospital, also working with their cancer center as well, and Advocate Good Samaritan's emergency department. But moving forward, now that we've kind of reached somewhat of a plateau, I think, in insuring people and finding the folks who are uninsured and getting them the coverage, sure, there's some churn and there's always some work to do with that, but we've reached a level now where we do think we really need to focus, irrespective of the insurance status, and more about, what are these other factors that make them a high-risk group and need this intervention. So they're a familiar face in the emergency department, they have substance abuse issues, homelessness issues, really trying to key in on those needs more so than just are they uninsured. Health literacy needs, I think, again, goes hand in hand with the behavior change comment. Just sort of putting more education and coaching into knowing how the system works, what these terms are, and educating the group about healthcare, access to care, and things of those nature. IT functions, I think that's just sort of a reality of working in this space of EMRs and healthcare data. In a lot of physicians' offices, I think that they're still using fax machines, and that's just kind of what I'm speaking to there, is that more integration through those data systems is something that we'd like to push for and see happen. And then, of course, we're always interested in expanding the model. So if there's partners in healthcare that feel that there's a gap and that this intervention could help that patient population or the population that you serve, we'd be interested in talking and figuring out how we can make something happen there. And the last thing on Engage DuPage, I just think the biggest sort of lessons learned, the need is really evident to us. We see that the care gaps are there, that those remain. We know, as we're here talking about, healthcare is an industry that's just in a major state of flux. There's massive shifts. There's a lot of pressure on the hospitals to do things differently and look at population health and look at accountable care. And so I think that pressure, that strain on their systems is something that tees us up nicely to work together and know that this type of public-private partnership is a solution with potential. I think that we also feel like the need is evident just because once we get into these settings, we feel very popular. We feel like the other departments and staff and they start saying, oh, well, can they help us with this group we're having over here? We're having this problem. So, just anecdotally, that's kind of how we ended up in the cancer center with an ambitious social worker there that felt like, hey, we really need some help over here. So I think that in a lot of ways we know this need is evident to do this kind of work. And ultimately the biggest lesson learned for me is that the collaboration is key. So having the buy-in from all the stakeholders, it sounds kind of obvious, but in real time you kind of see that the leadership of someone like Tammy Presley, like Candace and Catherine, their team, is absolutely essential for us to be able to actually do this work. So getting that buy-in from stakeholders in our community, getting that buy-in from the stakeholders in the actual health systems, all very, very important. And so I think at the same time, that collaboration, again, hammer the point on the need to share data and figure out solutions there, and ultimately that belief in collective impact, and that kind of together we make a bigger impact and we're able to really make a meaningful difference for the residents of DuPage County with that type of collaboration. So I know we're a little tight on time. I'll roll right into kind of what we're doing about Open Enrollment 5 to get DuPage covered. Again, if I think in DuPage we don't really wait on Congress to act, nor should we. I also think that while we're monitoring all this stuff very closely, we don't get distracted by it either, and we say, let's work together and let's figure out how we're going to navigate this space together in our community. Not going to spend much time here. This is just showing you that in 2013, the rate of uninsured was pretty high. That's correlated with dark purple, and you can see if ACA has accomplished nothing else in those 3-4 years, that it's really put a dent in the uninsured rate. And DuPage County and in Illinois, you can see we're right in that lighter shade of the map now. So we've seen a lot of improvement in our region. In DuPage County specifically, with the most recent data that we have, we know that there's almost 137,000 enrollees in Medicaid in DuPage County. and we know that there's almost 36,000 residents in DuPage enrolled in marketplace plans. We know that those enrollees on average receive a tax credit of $338. That's almost 28,000 of those folks getting those tax credits, and that's the average amount that they got for this year, for 2017. And then we know an additional 16,000 of those enrollees were eligible for the larger subsidy, the CSRs, as we talked about before. So that's just kind of a snapshot of who's using the ACA, the marketplace, the expanded Medicaid. I think that there's a couple important things to note on this slide. So this is the enrollment for 2017 in the marketplace in Illinois. And you can see DuPage is second, of course, in total volume. We are also second most populous, but I think we've also done a really nice job in collaborating and connecting people, which is evidence in that our sort of proportional rate of enrolling is the highest of any county in the state. So I think we said it was roughly 3.8%.
3.8% compared to, I think, 2.7% in Cook County and 3.2% or so in the other columns.
Is the next highest, yeah. So proportionally, we know we're doing a very good job. The other thing to point out here is that there were the new enrollees. So that last bar there at the bottom is that there was over 10,000 new enrollees to Marketplace in 2017. That was through OE4, that there was over 10,000 new DuPage County residents that enrolled in the Marketplace. And that tells us a couple things, I think. It's one stat that tells two stories. On one hand, a little bit of inconsistency in the plans that were offered. So without that continuity, people, in a sense, are forced to change plans, but also that group is really proactive, right? So if you combine the new with the active re-enrollees, that you see basically what we said about 5 out of every 6 had to be proactive in the open enrollment process. So again, that tells us that we're proactive and that they're engaged and that there's need. And those are good things. At the same time, that sort of lack of continuity in the plans offered each year drives that. So sort of two sides of the same story. Kara, is there anything you'd add to that?
No, I think you said it really well. I would just say that it's the vulnerability of not having navigation resources. So if you're looking at 29,000 out of 36,000 that needed to actually get in and make active changes, and you don't have adequate supports for that effort, you're really in a pretty vulnerable situation.
Thank you. So what are we, in preparing, we know that there's all these challenges. Nadine pointed out the sort of the sabotage tracker, and we know just sort of this year's the shortest open enrollment period, 6 weeks, just 45 days. We know the headlines confuse people. We know that there's the reduction in the navigation investment. We know that all of that results in there likely being less plans. And we also know that as far as special enrollment periods go, that they sort of change the certification process. There's more verifications needed. It's a little more challenging, a little more difficult. So we had to take all of those things into consideration as we move forward in preparing for Open Enrollment 5. This stuff, basically this is what we still want consumers to know. Open enrollment is here. Yes, it's shorter, but it's the one time each year that you have to change your plan, change your level of coverage, find a different plan with lower premiums or different networks. The timeline, as I mentioned, you can see it's only 6 weeks, 45 days, starts November 1st, goes till December 15th. If you enroll at any point in that time, your coverage starts effective for January 1, 2018. Now, that timeline is important because, as you've kind of already heard, it overlaps with all these other things. We know Medicare enrollment's going on right now. We know at our state we're launching the second phase of the IES. We know that our state we're making major, major changes to Medicaid managed care, and that's all happening at the same time. So that's yet further rationale for us sticking together as we work through this. So what are we doing? I think this is my last slide. And this is what we're doing. We stitched together over the last 5 or 6 weeks or so about 30 plus community partners across sectors, invited them over to the health department, talk about what we wanted to do. Everybody, these 30 partners or more, were willing to be involved and support in some manner, whether that's helping us just promote, just get the word out, do outreach, whether it's organizations that have assisters, navigators, and they were willing to offer their folks to our events, or a lot of groups are actually hosting events. And again, I was pleasantly surprised. We've had to turn some people down because we don't have enough days on the calendar. We don't have enough hours in this time to actually do all of the events. So right now we have 20 events scheduled, different parts of the county within those 45 days. And we will start live scheduling those at the health department there, dedicated from the health department. We will start taking calls and scheduling appointments into those community enrollment events next Wednesday on the 25th, 8 a.m. That line will be up and ready to start scheduling. That website should be up sooner. I'll get those materials out to everyone. That will sort of drive the traffic, just provide some basic information, help people get prepared for those events, attending those. Lastly, I would just say we also do have a limited number of appointments that we will offer for DuPage County residents through the health department for one-on-one marketplace enrollments. And I say that number is limited simply, again, because of the limited number of days and resources that we have. There is the events that we host, we're calling them review and renew workshops. The best candidate to come to one of those events is someone who's actually used the marketplace before and is looking to re-enroll. Those that are newer to it and have maybe some other more complicated needs, those would be the ones that we want to prioritize in the individual appointments. So that is everything that we're doing. And
do you have tablets then? You just have a bunch of tablets and you're doing it in real time?
so we have laptops, and our partners all have computer terminals or laptops.